So in environmental hazards, you will get these things. You have to cover this topic. There are two parts. One is the environmental hazard and the toxicology. And regarding the environmental hazard, you will get question from the drowning, burn, and mainly the thermal disorder. Though the electrical safety, environmental, and plastic injury, breakdown, bioterrorism is there, but main three topics: drowning, burn, and thermal disorder. The next slide, please. In toxicology, you will get a question from carbon monoxide, tricyclic antidepressant, and also paracetamol poisoning, opioid poisoning, and organophosphorus poisoning. Remember, in EDIC exam, it is a European exam, so organophosphorus poisoning is not very common. Snake bite is not very common in there. In your IDCCM exam, you will get question from the organophosphorus. You will get question from the snake bite. But in European exam, you will get more question on the paracetamol poisoning, TCA poisoning, carbon monoxide poisoning, and opioid poisoning, cocaine poisoning. So next slide, please move to. So now we will start some question and the explanation, little bit theoretical discussion. So following statement are true about the drowning. So drowning is the second leading cause of unnatural death after road traffic accident. The driving response occurred due to cold water stimulation and ophthalmic division of the trigeminal nerve. It is unusual to find little or no fluid lung in a drowning victim, and there are significant clinical difference evidence between patients who have been submerged in the salt water compared in the fresh water, affecting outcome and major electrolyte abnormality secondary to aspiration of the large fluid are the common after drowning. So you give your in the chat box, you give your answer, please. This is a K-type question. Okay, so little bit theoretical discussion that drowning is the second leading cause unnatural death after road traffic accident. This perspective of the epidemiology in the Western country, not in India. So yes, if you go through the epidemiology, drowning cause estimated 4 lakh death worldwide per year, and in Europe, European country and America, there is the second largest after the road traffic. And there is a voluntary apnea and reflex response occur after submersion in a cold water, that is called driving response, characterized by apnea, marked generalized vasoconstriction, bradycardia in response to cold water stimulation of the ophthalmic division of the trigeminal nerve. And blood is the shunted preferentially brain and heart. And after airway immersion, breath holding followed by laryngospasm, because it is a cold water drowning, and this cause progressive hypoxemia, hypercarbia, eventually resulting relaxation of the airway reflex and water aspiration. Up to 22 ml per kg water has been estimated to be maximal survivable inhaled water volume. So if the inhaled water volume more than 22 ml per kg, there is a chance of less survival. And there is a phase of secondary apnea and loss of consciousness. So salt water versus fresh water drowning. Remember, in the salt water, the osmolality is high, so it causing the dragging fluid from the interstitium, causing hypovolemia, hyponatremia, hemoconcentration, and pulmonary edema. In contrary, when it is a fresh water. So contrary with the fresh water, it's a hypoosmolar things, so it causing the hypervolemia, it causing pulmonary edema, it's removal surfactant, and dilutional hyponatremia, hemolysis, and clinically detectable difference pattern of the lung injury, salt and fresh water, but in terms of mortality, there is no significant change, and difference in electrolyte disturbance are not generally clinically significant. So water contamination and the temperature in the fresh water, this is a burden. This is a the media for the gram-negative, predominantly the anaerobes, staph aureus, and fungi, protozoa is there. So there is a chance of infection is high. In a temperature, cold water submersion determined cold shock response, and it ultimate cause the cardiac arrhythmia. Therefore, if you are a strong swimmer, you can swim long time in the cold water, and therefore swimmer may down quickly in the ice water. So swimmer, the swimming can't help in a cold water. Next slide, please. Next slide. So management in a drowning,
No, sir.
management. Yes. Yeah. So basic life support, respiratory support, cardiovascular support, and the cerebral protection. These are the outline of the basic management. Next slide, please. And you have to prognosticate when you will get patient for the drowning. That is predictor of the death and severe neurological impairment. One is at the site of immersion, whether it is a more than 5 minutes, delayed CPR more than 10 minutes, Glasgow Coma Scale 3, or fixed dilated pupil. And when patient you receive in the ICU, whether Glasgow Coma Scale is less than 6, metabolic acidosis, and there is an abnormal CT in 36 hours of submersion, and no response or very abnormal response brainstem function after 48 hours of immersion. Now coming to our question, the following statements are true about the drowning. Drowning is the second leading cause of unnatural death after road traffic accident. True or false? It is true. Drowning is characterized by apnea, generalized vasoconstriction, bradycardia, resulting in shunt of blood, heart and brain. Yes, true. It was initially postulated laryngeal spasm occur in approximately 15% of drowning, resulting dry drowning, and now thought to death without pulmonary aspiration rarely occur. It is also true because of the laryngospasm happening in the cold water submersion. And submersion of the salt water compared with the fresh water, no thought to make significant clinical difference in the outcome. False. There is no clinical significance difference due to the due to the electrolyte abnormality. And major electrolyte abnormality secondary to absorption of large fluid volume patient with drowning are rare, and unless drowning occur extremely electrolyte rich fluid, it is also false, because major electrolyte abnormality happen in both the case. One is due to hyperosmolar fluid, on other is due to hypoosmolar fluid. Next question, drowning, protective hypothermia usually occur. Driving replace characterized by apnea, vasoconstriction, bradycardia, and if hypothermia is arrested, down patient should kept cool during resuscitation. This may improve neurological outcome. And fourth option is 5 rescue breaths should be delivered when commencing and cardiopulmonary resuscitation. Immersion time should be considered in the decision whether to continue or cease the resuscitation. So please put your question answer in the chat box. Please give your answer. Fourth and fifth option is true and rest is false. Submersion in the ice water may lead to protective hypothermia, but this is not common in diving reflex should occur due to cold water submersion in ophthalmic division of the trigeminal nerve. And second, the attempt should be made raise body. You can't do uh, this resuscitation in a hypothermic situation. You have to warm up and you have to do hypothermia. You have to do resuscitation, then you will get a good outcome. And 5 rescue beds should be delivered when commencing CPR. Yes, immersion greater than 10 minutes have a prolonged asphyxia, so neurological outcome will be not good. So 45-year-old man extracted from the local canal after drowning. He has a severe hypothermia. Which of the feature would be expected on the ECG? Atrial fibrillation, short PR interval, bradycardia, and ventricular ectopic. Negative deflection junction of the QRS and ST segment of the chest lead. क्या आंसर होगा? Anyone? So you have given all T and someone FT. Okay. So let's see. FTT. So why first one is F. The negative deflation at the junction of QRS ST segment is lead to chest lead. Explanation: hypothermia defined as a core body temperature less than 35 degrees Celsius. Mild hypothermia 32 to 35, moderate hypothermia is 29 to 32, and severe hypothermia less than 29. Hypothermia may produce following ECG change. One is bradycardia, such as sinus bradycardia, AV block, atrial fibrillation, slow ventricular response, slow junctional rhythm. 𝐴𝒂𝒂𝒓𝒏 wave and artifact due to severing, prolonged peak QR interval and ventricular ectopic, cardiac arrest due to asystole and ventricular fibrillation, ventricular tachycardia. These are the changes occur, and 𝒁 wave is not, it is a common finding in the hypothermia, but remember it can also be happen in a hypercalcemia situation, in a intracranial hypertension, head injury, subarachnoid hemorrhage. This is a Osborne wave or J point. Now coming to the another question. Next, please. Next, please. Next, please. Yeah. So 19-year-old male is brought by ambulance to the ED after near drowning episode in which he was caught in a riptide, and rescue extracted him from the water within 20 minutes. On the scene, he was coughing and mild confused. On arrival to the ED, found awake, alert, and initial oxygen saturation 85% on the room air. Supplemental oxygen is administered via aerosol face mask at 10 liters per minute. After 30 minutes, his oxygen saturation raised to 90%. He remained awake and is no distress. What is the best next step for management? घर छोड़ दोगे? So oxygen saturation 90% is sufficient. Trial him off face mask in preparation for discharge from the ED. Use Helmich maneuver to extract additional fluid from his lung. Intubate the patient and perform bronchoscopy, clear aspirate fluid. Initiate non-invasive positive pressure ventilation such as BiPAP. So somebody says most of the people are answering D. Yes, why? Yes, because in near drowning situation, symptomatic patient can be hypoxic on arrival ED. In this case, supplemental oxygen should be administered in order to maintain oxygen saturation more than 94% and the PO2 more than 60. And is not sufficient to give only oxygen. Non-invasive positive pressure ventilation like CPAP, BiPAP, or high flow nasal cannula can deciding to intubate the patient. So if you give the positive pressure ventilation, it helps to uh, prevent collapsing of the lung and better oxygenation. And your target PO2 always should be more than 60. So another question, 34-year-old woman, female, fell off a dam into a lake while intoxicated. She was extracted approximately 10 minutes after the incident. She is unresponsive on the scene. Rescue breath was initiated in onlooker. On EMS arrival, she has a pulse and her respiratory rate is 10. Supplemental oxygen administered. She brought to the ED. On arrival, her GCS is 8. Her oxygen saturation 85%, 15-liter non-breathing marks. She is intubated and she following through regarding freshwater versus saltwater drowning. This is a K type of question. Tell me, patient who suffer near drowning in the salt water versus should be managed similarly, yes or no? You just put matchbox Y or N. Okay. Yes. Very good. Salt water ingestion result in hyperosmolar load and patient benefit from decompensate desmopressin administration. True. Yes. Fresh water ingestion result in hypoosmolar load and this patient benefit with diuresis with furosemide. Y or N, T or F. Fresh water ingestion result hypoosmolar load and this patient benefit from diuresis with furosemide. Somebody says F. Rest. True. Okay. Patient salt water ingestion more prone to develop pneumonia. F or T. D, option D. False. Yes. So ingestion, one of the near drowning of salt water versus false previously thought cause of different effect on the lung parenchyma, but now have been demonstrated that there is a unlikely to be significant difference between salt water and freshwater ingestion. Therefore, two groups should be managed similarly. It was previously thought that ingestion salt water resulted in hyperosmolar load to the increased osmolality of the plasma. It has since been demonstrated that amount of water usually ingested during near drowning incidents is not generally enough to confer this type of effect, whether the water is hyperosmolar or hypoosmolar. In case of freshwater ingestion, therefore neither. So there is no much effect on the in the systemic effect. Okay. Desmopressin administered और furosemide दोनों ही indicated नहीं है because this is not causing much harm on the systemic effect because it is all about theoretical and due to your laryngospasm, due to your this reflex in the cold water, it's all about in the western country question. So all about the cold water things, not think about our in the Indian scenario. Although there are different organisms tend to raise in the salt water and the freshwater ingestion, one of the other not particularly associated increased risks of pneumonia. So the last option also is telling false. Now coming to the hypothermia, the another next slide. Yes, hypothermia. So in hypothermia, you will get repeatedly one or two questions on therapeutic hypothermia And in practical, they will ask about therapeutic hypothermia, the methodology, the evidence behind it. Though the recent evidence all are saying that therapeutic hypothermia is a myth, it's not going to help you a lot. But definitely, if you maintain the mild hypothermia, means less around 35, 34 to 35, it has some benefit. But therapeutic hypothermia, as the recent trial, are not supporting. So the question is therapeutic hypothermia after cardiac arrest directly decrease intracranial pressure, promote intracellular movement of cases, because having the data wave of the electrocardiogram, the aim to achieve core temperature 32 to 34 degrees Celsius and should only be used. Initial regime was ventricular fibrillation and tachycardia. So what will be your answer? 𝑇𝑇FFTT. Anyone? So therapeutic hypothermia promotes cerebral vasoconstriction and reduce intracranial pressure is true. Therapeutic hypothermia